Today we are going to study about recent advances in treatment of the diabetes. So, what is diabetes? Diabetes is a group of metabolic disease characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. Either the insulin secretion is defective or insulin action is defective. Types are 1, 2, or gestational diabetes and many other forms of diabetes. It's prevalent in 537 million of individuals. In type 1 diabetes, there is environmental and genetic factors which are causing it. Activation of immune cells, autoimmune response, and then beta cell destruction. Autoimmune response results in the destruction of the beta cell and causing the beta cell deficiency. When the beta cell is deficient, there is a decrease in the formation of insulin. So occurrence of autoimmune antibodies in case of activation of immune cells, they are causing decrease in the insulin and C-peptides resulting in the beta cell deficiency also. So resulting in decreased insulin and C-peptide and diabetes mellitus. In type 2 cases, genetic predisposition and constitutional factors resulting in the insulin resistance. There is a genetics involved more in type 2 cases, and predisposition and constitutional factors like lifestyle factors. So insulin resistance is happening, and beta cell dysregulation it's causing then impaired glucose tolerance. When glucose tolerance impaired and beta cell ki insufficiency, it's because of insufficiency, impaired glucose tolerance resulting in diabetes mellitus. In case of insulin resistance, there is insulin but still it is not working at the cell level. And beta cell insufficiency means all insufficient insulin is getting released. So this is type 2. Then for criteria for diagnosis, HbA1c more than 6.5%, fasting plasma glucose more than 126, and 2-hour plasma glucose more than 200 mg per dl. And random plasma glucose more than 200. These are the symptoms in case of diabetes we see. Now what is happening? How the insulin is being released? In pancreas, we are seeing the islet of Langerhans. In islet of Langerhans, there is a three types of cells: A cell, B cell, and delta cells. So we are right now seeing B cell. So in case of B cell, the glucose is entering inside the B cell by GLUT2 glucose transporter at the pancreas level. Then glucose is converted to glucose 6-phosphate by glucokinase, which is converting to glycolysis. By glycolysis, it is converting in the mitochondria. Glycolysis is happening and resulting into ATP formation, and this ATP formation is causing the potassium channel inhibition, and that potassium channel inhibition causing the depolarization. That is, inside the channel, inside the cell membrane, there is a potassium ions, and outside there is a negative ions. This is resulting in the depolarization. This depolarization causing the opening of the L-type calcium channel, and that stimulation is causing inside the calcium influx. And as the calcium is influx happening, so insulin granules getting stimulated, and when these granules are stimulated, these insulin pockets are being at the insulin receptors, and they secrete the insulin outside into the blood. So we are having the insulin preparations: ultra short acting, short, intermediate, long, and inhaled insulin. That is the new, that is Afrezza. In case of ultra short, we have Lispro, Aspart, and Glulicin. Lispro and Aspart itself is showing very short name. Then short acting, ultra short, and short acting is regular insulin. Regularly we give short acting insulin. Intermediate acting insulin, neutral, protamine, hagedron, NPH insulin, and insulin zinc, that is Lente. Long acting insulin is insulin glargine. Glargine is also saying large, long acting, insulin detimer, and insulin degludec. DD is बहुत ही दूर तक जाएगा. That is insulin death means insulin deglutec. Then adverse effects of insulin preparation is hypoglycemia. Of course, we are giving insulin, so it may result in decrease in the blood glucose and weight gain. So as insulin function is increasing the glucose uptake inside the cell. So more the glucose uptake inside the cell, it will result in hypoglycemia, and more inside the cell glucose uptake. So it will cause the glucose inside the cell and resulting in weight gain. And lipodystrophy is also resulting. So what is happening here? Mechanism of action of anti-diabetic drug we will see. So at the level of pancreas, sulfonylureas work and they increase the insulin release. So they are insulin secretagogue. They causing the release of insulin. Though sulfonylureas secreting, है ना? तो insulin release increasing. Then DPP4 inhibitor or GLP-1RA. They are causing glucagon secretion inhibition, decreasing the glucagon secretion as the glucagon will be less. So insulin and glucagon are opposite. Glucagon is causing increase in the blood sugar level and insulin is causing decrease in the blood sugar level. So they DPP4 inhibitor and GLP-1RA causing decrease in the blood glucose level by decreasing the glucagon secretion and increasing the insulin secretion. Metformin, that is a biguanide, increasing the glucose uptake, and TZD, that is thiazolidinediones, they are increasing the glucose uptake. At the skeletal muscle level, metformin and this thiazolidinediones are working, like pioglitazone. Now at the liver level, metformin is working, that is in decreasing the gluconeogenesis, as the no new glucose formation will happen, so decrease the blood glucose level with the use of metformin. TZD is also causing the increase in the insulin sensitivity. At the muscle level, their metformin and TZD is increasing the glucose uptake, so that more glucose being taken by the skeletal muscle level and more energy production. And at the level of liver, metformin is causing decrease in gluconeogenesis, decreased new glucose, that is decreasing the blood glucose, and TZD increasing the insulin sensitivity. So at the liver level, it is causing the cells to uptake the glucose and storage. Now SGLT2 inhibitor, they are increasing the renal glucose excretion. They are new, canagliflozin, empagliflozin, dapagliflozin, they are SGLT2 inhibitors. In adipose tissue, TZD is causing increase in glucose uptake. At the adipose tissue level and at the skeletal muscle level, both level, TZD is causing increased glucose uptake. And at intestine level, GLP-1RA causing decrease in gastric emptying, and DPP4 inhibitor is causing increase in GLP-1, and metformin is causing increase in GLP-1. GLP-1 is glucagon-like peptide and decreasing the glucose absorption.